I tried to add in some examples that are pediatric specific too, just because these are pervasive issues sort of throughout the medical field. Um, I'll start by my financial disclosures. So I was supported doing this research the summer after my first year of medical school by the Pritzker Summer Research Program, as well as the National Institute of Aging P35 training grant. The database, the site source of the data that I used is the National Social Life Health and Aging Project. I'll talk more about that in a little bit, but it's also supported by the National Institute of Aging through a number of grants, and then no other disclosures. So I just want to start by sort of discussing the medical and social model of disability. I'm sure that at the CED, you guys are all very much aware of sort of this dichotomy or the two ends of the spectrum, sort of when we think about disability. And so maybe this is all a rehash or refresher for you, but I think it's important because it provides a useful framing for the paper and the conversation that we're going to have today. So from the UCSF patient-centered care website, they sort of describe the medical model of disability as, quote, views disability as a defect within the individual. These defects must be cured, fixed, or completely eliminated. Healthcare and social service professionals have the sole power to correct or modify these conditions. In contrast, the social model of disability is the inability to participate fully in home, community life, physical and social barriers to full participation, creating disabling environments. Disabilities are restrictions imposed by society. The solution, according to this model, lies in not fixing the person, but in changing our society. I think it's really just important to bring this up because I think a lot of medical providers, people in the healthcare field in general, many with the best of intentions tend to identify very strongly with the medical model of disability. But unfortunately, that can lead to pretty paternalistic practice and pretty rampant ableist bias in sort of how we practice healthcare and make decisions. So I just want to put that out there as sort of the framing for the subsequent discussion we're going to have. And so I'll start by just giving some baseline statistics, right? We live in an aging society. The World Health Organization estimates that the number of adults over 60 will double by the year 2050. And taking care of the mental health of an aging population is really important because it's estimated that 20% of people over the age of 55 will experience some sort of mental health concern. In the US specifically, many older adults experience some degree of sensory disability. 94% experience disability in one of the five classic senses. So that's hearing, touch, sight, smell, olfaction, and taste. And then 67% experience some disability in at least two of the five classic senses. And so, because, all these things considered, we live in an aging society. Older people tend to experience sensory loss, sensory disabilities. And unfortunately, there's been some evidence to show that various types of sensory disabilities may be linked to mental health concerns. And here are just some representative papers that sort of go into that. But broadly, sensory disabilities fall into this sort of nebulous broad category of what is called like a quote invisible disability. Chloe Orkin is a disabled physician out of the UK, and she wrote a really excellent sort of reflection piece on her own disability. And I just want to share like a portion of that with you. And he wrote, quote, I was met with skepticism. People who had not witnessed the worst of my problems firsthand seemed to think that my weird constellation of invisible problems must be exaggerated, psychological, both. And so I just want to share this quote to sort of emphasize the nature of the culture of medicine and just the general sentiment towards disability and why it's sort of important to talk about these sorts of these issues and do research on these topics. Sort of as alluded to by Dr. Orkin, sensory disability is associated with stigma and worse mental health. Particularly, these older adults are at risk for stigma and ableism. Previous work has found that various types of sensory disabilities are linked to increased depressive symptoms, increased feelings of loneliness. There was a New York Times article, I forgot what year it was from. I put a screenshot of the headline on the screen, but it it describes how, when given the sort of guise of anonymity, many physicians express not wanting to take care of disabled patients, which is really, really heartbreaking, really disheartening to hear, but unfortunately is sort of the culture of medicine right now, right? It's not everyone, certainly, but this sort of gives a lay of the land, so to speak. And so even though I'm telling all this background information, there's still gaps in our understanding, even though we have a growing need. Previous studies have looked at a sort of limited scope of sensory disabilities. The two that scientists tend to hone in on are vision and hearing. Um, and there's a limited array of mental health outcomes. They most often looked at depression, some anxiety, some loneliness, but they tend to hone in on one sort of mental health scale. And then throughout a lot of these articles, there's potentially stigmatizing language. And so I think as an exercise, I think it's important to write, scientific papers that try to minimize that and at least put that out there. And so we have a incomplete understanding of the sort of complex relationship between sensory disability and mental health. And so our goal with this study was to try to address this knowledge gap. Um, The database that we used is called the National Social Health and Aging Project. It's a really, really cool project. It's a longitudinally nationally representative study of commuting dweller older adults using professionally trained interviewers. So community dwelling meaning that they're not in skilled nursing facilities, they're sort of out and about in the community. Um, Here's a screenshot from the NSHAP website, sort of describing it, but I just want to point out this study has been ongoing functionally for 2 decades at this point. They started data collection in 2005, and then collect data pretty much every 5 years. And currently there's a ongoing data collection, but our study looks at data from the first 3 rounds of NSHAP. So that's the 2005 to 2016 data collection. So NSHAP has been used to study a number of topics relating to aging, which is in large part due to the broad spectrum of information that they're able to collect in the study. On the screen are some of the representative articles that they even highlight on the NSHAP website. But some of the information they collect is things related to physical health, to mental health, and then sensory function. And it's worth noting, I'll mention now that because NSHAP is sort of an iterative process, some of the data collection varies between waves. And so with sensory function specifically, there was some variation in how they decided to collect measures of sensory function. Jumping back into our study, we used the following data from NCHAP. So for vision and hearing, this is an example of where some of that data collection varied. And so across the first 3 waves, the consistent marker that they had was sort of a perceived burden using the professionally trained interviewer ratings. They would rate the participants in NSHAP from 1 to 5, with 1 being, quote, practically deaf or practically blind, and 5 as, quote, normal hearing and normal vision. Ratings of 3 or less were characterized as having a sensory disability in that specific sense. For olfaction, NSHAP collected information using a previously validated assessment. I think it's called like SNF 22. Participants are basically asked to identify 5 distinct scents using like felt tipped markers, and participants that are able to identify 3 or less scents are characterized as having a olfactory disability. And so in addition to sort of tabulating these three types of disability, we also just tabulated the number of disabilities that each participant had. And then the other thing, the gap that I mentioned is sort of a limited range of mental health outcomes. So we wanted to look at a really robust range of mental health outcomes and look at a lot of different ways that this is sort of affecting people. And so one of them that we used is self-rated mental health. And previous work has found that self-rated mental health is a good single unit measure of mental health because it also captures factors like mental health service utilization as well as satisfaction with care. Um, the other outcomes displayed on the screen are based on previously validated tools. So frequently depressive symptoms is based on the Center of Epidemiologic Studies Depression Scale. Frequent perceived stress is based on a perceived stress scale. Frequent anxiety symptoms is based on the hospital anxiety and depression scales, anxiety subscale. Um, Frequent feelings of loneliness is based on the revised UCLA loneliness scale. And then there are these are various scores and there's cutoffs that the NCHAP people determined in order to match the sort of epidemiologic uh, prevalence of each of these sort of symptom burdens within the general population. And then finally, the covariates. We included covariates that we thought were based on our literature review may impact either sensory function, mental health, or both. And so they're divided into sort of three broad categories. You have demographic factors, age, sex, race, ethnicity, socioeconomic status factors, so highest level of education, and then whether they're married or living with a partner, and then health status and behaviors, Charlson Comorbidity Index to get a general sense of their health status. Cognitive function, I put z-scores because this is another one of the metrics that they changed in between waves of data collection. So we had to standardize them somehow and look at how much scores deviated from one another using z-scores. And then whether or not they're a current, former, previous smoker, never smoked, and then whether or not they had heavy alcohol use as described by the CDC definition of heavy alcohol use. And so the last sort of like thing about how we did our study is we did a time to event analysis using Cox models. So the time at which a participant entered into the NSHAP study was defined as their initial time point T0, and then the onset of a mental health condition above a threshold, again, as set by the NSHAP based on sort of epidemiological prevalence, was defined as the event. And then we adjusted for all the previous covariates that I described. And we had four separate models. So we had separate models for each sensory disability, and then a fourth model looking at the number of sensory disabilities. Okay, so that's a lot of the setup for sort of what we did. And now time to get to the fun stuff, the results. Um, this was how the sort of our cohort looked, our study cohort. And you can see it in round one. That was sort of the first measure of participants. Round two, the reason it goes up is because in round two they added original participants plus co-resident partners, spouses, those types of things. And then round three, the reason it goes down is because they interviewed people from rounds one and rounds two, but some of them had passed away at that point. And so when we pool these, we have around 4,000 unique individuals that entered NSHAP at some point. And then we looked at which questionnaires they answered, again, because NSHAP is it's an interview-based study. People can opt in or opt out of certain aspects of it. Fortunately, the majority of people opted to participate, and we had pretty robust sample size of around 3,000 unique older adults that answered a lot of the questionnaires. And so this is sort of a splicing of what the cohort characteristics are. We divided the cohort based on the number of sensory disabilities that they had. with participants with 0 disabilities on the left, and then 1, 2, and then 3, moving from left to right. Um, if we look at just the number of sensory disabilities, we see that a lot of people were characterized as having no sensory disabilities, and then there was about 1,000 with 1, and then 500 with 2, about 150 with 3. And then if we look at the prevalence of each type of disability, we see that olfaction is the highest sort of singular sensory disability, but then when we get to 2 and 3 sensory disabilities, hearing and vision have a pretty significant jump up. The other thing I want to point out on this slide is the self-rated mental health stratified by number of sensory disabilities. We see that there's a trend downwards. As you have more sensory disabilities, the self-rated mental health goes down. And this is sort of an unadjusted model. And so, this is without controlling for other covariates, but it gives us an idea of what the sort of trend we might be seeing. And then as well, we see a similar in just the percentage of respondents that rated their mental health as poor or fair. Again, here's more characteristics. Again, I just sort of talking about all the mental health markers that we used. We see sort of a similar trend, especially with depressive symptoms. As people had more sensory disabilities, they had more frequent depressive symptoms. Same sort of picture with perceived stress, more sensory disabilities, more perceived stress. We did not see a sort of significant trend with anxiety symptoms. We see like they increase, but not significantly. And then loneliness, again, we see a significant sort of increase in the number of loneliness symptoms as the number of sensory disabilities goes up. And so this figure is from our paper and sort of summarizes some of our findings relating to the number of sensory disabilities. I just want to highlight the sort of dose-dependent response that we see, particularly with self-rated mental health and loneliness symptoms. Even after controlling for all the covariates, we see that sort of as you get more sensory disabilities, there's a dose-dependent effect on feelings, your self-rated mental health and feelings of loneliness. You don't see the same dose-dependent effect with depressive symptoms, stress, anxiety, but loneliness and self-rated mental health, you see that dose-dependent response. And then different types. When we stratified by had separate models for each type of disability, we saw that there was not every disability had the same relationship, right? Vision in particular was significantly associated with worse self-rated mental health and more feelings of loneliness. And so I've been talking a lot about sort of methodology and results, but in summary, right, a greater number of sensory disabilities was associated with lower self-rated mental health and more frequent loneliness symptoms. And different types of sensory disabilities were differentially associated with the mental health outcomes. And in particular, there seems to be something unique about vision disability because it was significantly associated with lower self-rated mental health and loneliness. And, those findings in and of itself were sort of interesting but I think with any scientific process, once you get sort of interesting findings and interesting results, it opens a whole new can of worms and shows us new sort of complex relationships and new questions that we have to ask ourselves. And I'll sort of these are the ones that we sort of discuss, and I'll talk through each one of them sort of individually. But the three that really came to mind for me when I saw this initial set of results is how do the sort of individual sensory disabilities have additive effects causing worse mental health? Why do all three disabilities seem to have the strongest relationship with self-rated mental health in particular? And why was olfaction not associated with any of the mental health outcomes? Because it had been associated in sort of previous articles. And So I'll talk through these sort of one by one, but the sort of additive effect, right? How do the individual disabilities have an additive effect, right? And here are the two tables with some of our models, and we see that dose-dependent response for the number of sensibilities. But when we look at the individual senses, it's not really as clear how the additive effects impact mental health, right? We sort of see I mentioned vision, but hearing is probably the one that looks like it's trending towards significance, but it's like just below that sort of t equals 0.05 threshold that many in the scientific community feel is like the marker of significance, right? And so this begs the question, like, what is preventing? Like, what is acting as a sort of protective factor that is not preventing hearing disability from being significantly related to loneliness and mental health. And so, one explanation for this, and I think reasonable explanation, is the protective effect of community. And we looked at a couple of articles and we saw that a strong sense of community can really serve as a protective factor for mental health. And some of these studies, the one on top in particular, looked at college students living in a dorm that had a disabled community. And they found that it was a really good protective factor for mental health. And so if we sort of jump outside of the study, right, and dig deeper into this idea of community as a protective factor, I'll use the deaf community because it's we're sort of talking about hearing disability, but it has a very deep and rich culture. In the time period following the American Civil Rights Movement, many deaf activists used this momentum to fight for civil rights and recognition of deaf culture, right? We see this picture on the top right. I believe that is at the time the president of Gallaudet University. I'll get to that. He's a deaf activist speaking. I believe that is in front of the Capitol building. And there's 300 plus dialects of sign language. And so the image on the bottom left of the screen is a little bit hard to see, but it's color coded and I found it on the internet, but it shows some of the linguistic origins of a variety of different sign languages across the world. So not even just regional dialects, but different linguistic origins from various parts of the world. And there's a lot of really rich history and linguistic diversity just from a historical standpoint, right? And then deaf universities, right? Gallaudet University, I mentioned earlier, was chartered in 1864 and continues to be an educational institution who has a mission of educating deaf students, providing like bilingual teaching. So I talk about all of this again, sort of jumping back into the study. I talk about all of this because it's possible that this community factors may be protective for the NSHAP respondents' mental health, right? And we're not able to really answer it with this current study, but I think it really begs the question and really, really should be investigated, like how engagement with the disabled community or broader community at large, just community engagement, this sense of community, can be protective and improve mental health. And I think also importantly, this really, really puts onus on medical professionals to try to understand these vibrant communities, to try to understand the disabled community and improve culturally sensitive care, which there's current studies that suggest it may be inadequate, right? And just some of the things I showed at the beginning of the PowerPoint, there's reason to believe that sort of culturally competent care is not there. The next sort of question that I had is, this effect is sort of the effect size, right? Like, why were all three of the sensory disabilities, like significant or not? Why was the effect size the largest for self-rated mental health? My sort of best explanation is this: is it's related to social, societal, healthcare, ableism, right? Our best theory is that by virtue of these older adults having disabilities, they're more likely to have more frequent interactions with the healthcare system, right? And so they're more likely to be subjected to ableism from medical providers, right? We saw the New York Times article, we saw some of the other things, the sentiment medical model of disability, all these things. And that in turn, right, ableism from healthcare providers is just an unpleasant experience for patients, but also maybe restricting the accessibility of mental health providers, right? Some of these doctors just may not want to see disabled patients. And so you get this really, really vicious cycle of barriers. And a theory for this is that this cycle of just being beaten down, being subjected to these barriers, reduces people's overall mental health, which manifests in the way of a decreased self-rated mental health rather than a particular subset of symptoms, right? So that was our sort of leading explanation for why this may be happening. And the last sort of question that I mentioned is why was olfactory disability not associated with any of the mental health outcomes, right? Like we sort of talk about hearing, there may be this protective effect of community. Olfactory disability, what is going on there? Um, One explanation is that olfactory disability is not regarded by society in the same light as other sensory disabilities. Social Security disability insurance is sort of an example of this. Um, in order to qualify, you have to meet certain criteria, and it's not the end all be all, right? Social Security does not define what is a disability and not, but I think it's a good stand-in for how our society may feel or think about different types of disabilities. And only very recently, and only in the context of long COVID, were things like gustatory and olfactory disabilities included. I believe it was in the of course, the post-COVID era, but very recently, up until then, these things were not included in the Social Security disability insurance, whereas other types of sensory disabilities weren't. Another theory is that there may be a shared underlying mechanism. It's previously described as GSI or global sensory impairment. And so Dr. Pinto, the person I worked on this, he worked with a team of researchers and they looked at sensory function and they, in essence, came up with this theory that GSI is a proposed underlying mechanism for sensory disability. Um, and so I'll sort of walk through these figures because they're a little bit confusing, but the figure on the left basically uses a generalized single factor measurement model to predict sensory outcomes using a single factor. That's what they dubbed in the paper GSI. And so on the figure of the left, we see that GSI is very strongly associated with hearing, vision, and smell. When they controlled for other factors, age, gender, race, they saw that olfaction and hearing were still strongly associated with GSI, right? And so the theory is the potential explanation is that olfaction, maybe to a lesser extent, hearing may be effect modulators for patients with sensory disabilities via this sort of shared underlying mechanism. And so I'm talking a lot and I'm saying a lot of words that are very confusing and it's very confusing for me, still is a little bit confusing to be honest, but the end goal is the relationship between sensory disabilities and mental health is very complex. It's not as black and white as I think a lot of people would want to make it out to be. It's a very complex situation. It's a lot of nuance. Um, and our study had a lot of strengths, but I think certain things may have enhanced our findings, right? Notably, we did not use objective measures of hearing and vision. Those just sort of the logistics of NSHAP. These are long interviews, and at a certain point, they have to make decisions on how best to spend their time. And so we used the interviewer rated hearing because that was what is available to us, and it's sort of a measure of some perceived burden, but is not an objective measure at the end of the day. Similarly with mental health, it's all these fact scales, they're based on previously validated scales, but they're a measure of symptom burden rather than clinical diagnoses. So it's possible that things may have looked differently if we went based on clinical diagnoses, but we just don't have that information, unfortunately. And then the most important limitation, I think, is there's a certain inability to capture the nuances of sensory disability and the full extent of life experiences. NSHAP is a study of older adults, so it's sort of impossible to really capture and really understand the 50, 60, 70, 80 years leading up to somebody's sort of interview in NSHAP, right? It may manifest in certain ways, but you really aren't able to capture the full nuance of those lived experience. And so that is a limitation of our study. And so the conclusions I think from this study is I think there needs to be an increased mindfulness of mental health in older adults. I think mental health screens, you know, can be sort of supplemented based on what type of sensory loss, what type of sensory disability older adults are experiencing, right? And I think as a field, there should be more community-based interventions when sensory disabilities are identified, right? This idea of community as a protective factor. And then particularly relevant for everyone and as, this is a paper talking about older adults, this is the Department of Pediatrics, like, this is, I think, the more important takeaway, changing physician perceptions of the disabled community, right? Um, the disabled community, in my view, should be viewed as an asset for psychosocial health of disabled patients, right? Old, young, doesn't matter. It should be viewed as an asset, and I think challenging the sort of built-in bias that may exist in some of the medical model of sociability and helping encouraging healthcare providers to have a more nuanced view, a social view, and even a binocular view, I think it's called, of disability. And I really want to emphasize this last point with some examples. So this was a 2023 article from the American Academy of Pediatrics. This research team, I think, is based at the University of Utah. They did a study looking at caregivers and the perceived disability-based discrimination in healthcare for children with medical complexity. And they talk about a lot of things, but in this particular table, they talk about one of the quotes and representative driving themes that the caregivers identified. And one of them is clinician apathy for patients with disability. And the quote says, when we had to leave that appointment and he had to know that the doctors didn't think it was important to help him, it was shattering. He pieces it together that there are things that the doctor won't take seriously because he's in a wheelchair. Um, I mean, just a devastating quote. I mean, it's really like this should not be happening to any patient. And I think this really emphasizes how this disability-based discrimination is a health equity issue. It's a health equity issue because this is not acceptable, should not be acceptable. And then finally, there's a 2023 article by Dr. Christopher Lunsford. He's a disabled PM&R physician, I believe out of Duke University. In the article, he discusses a number of different topics, as well as providing a really excellent practical guide for pediatric clinicians. In one particular section, he talks about the ICD coding term, quote, failure to thrive, as an example of how ableism is sort of baked into healthcare. And I want to highlight this sort of end quote because of how important it is, I think, to emphasize considering how we think about disability. So this is in the context of Dr. Lunsford talking with a mother and a patient with cerebral palsy. And he writes, she, the mother, couldn't understand what purpose we, the doctors, had for labeling sick infants as failures. Ultimately, I knew I could not defend the medical institution for using this term, failure to thrive, the same way I would not defend how long it took to retire terms like mental retardation or crippled, right? And so I think like I realize this talk is the paper I worked on was about older adults, but I think these messages, these themes are very broadly applicable in a variety of different settings. And so finally, before I sort of field some questions, I just want to acknowledge the Pritzker Summer Research Program and the NIA for supporting my work in this. Kristen, she's a data scientist in the University of Chicago Department of Public Health Sciences. She really was instrumental in teaching me the tools I needed to sort of ask these questions. a huge thank you to the NSHAP participants and the team doing the study. NSHAP is publicly, the data is publicly available, and so this is the website, the link that you can just go and you know, ask some really interesting questions. Also, the Sense Network, it's an international network supporting research on the role of sensory function on mental health and aging. And then a special shout out to the Johns Hopkins University Disability Health Research Center. I really have no affiliation with them, but I think the work that they do is really, really excellent and really powerful. Um, and so with that, that's all I have. I just want to say thank you all for um, giving me the time and the platform to sort of discuss this, and I'm happy to answer any questions.
Thank you very much. We appreciate your work in this area. As we go into the question section, remember to unmute yourself. But does anyone have any questions? Okay, I do. I can get us started while people are unmuting. So, what is your hypothesis of why you saw an effect for depression but not anxiety? Is that chronic versus acute, or what do you think is going on there, whether it's vision or hearing or any other?
Yeah, it's hard to say. I'm not entirely sure. I think the mechanism is sort of unclear. It's one of those things where I honestly don't have a good answer for it. It may just be sort of related to the way that people manifest like um general stressors is maybe more related to like
Can't
feelings of
hear.
depression or better
Can't
characterized
hear.
as depression.
Mhm.
Am I muted?
Lost sound.
Um, I
There.
I hear you're not muted. We hear you. We hear someone else who isn't muted. Go ahead. Keep going.
I just lost you for a second. I'm sorry.
Oh no,
I
that's
Oh,
all
couldn't
no
right.
hear
worries.
anything.
Can you hear us now?
I can hear you, but I can't hear Alexander.
Okay. Try it again, Alex.
Hello?
Okay, I
All
heard hello.
right. Yeah, I'm not sure, to be honest with you. I think it may just be like a manifestation of how people respond to sort of being beaten down by society, as harsh as that sounds. But I'm not really sure, to be honest.
Any other thoughts or questions? I know we have a particular group who works with, you had shown the article about from the parent perspective and the medical kind of evaluation or context. I don't know if there was anything in there that people might want to bring up.
I am a little bit curious, and I hope I'm able to articulate what I'm trying to ask. First of all, thank you so much for conducting and explaining this research to us. Um, I find I work with family systems, right? And so what I have kind of noticed is that many times the child, especially when the child can like express their identity, when we get more in the teen years, a lot of times I've seen a child will perceive their or express a different perception in their disability than the parent is expressing. Many times we see more resiliency in the child than in the parents. And I'm wondering if you've run into really just any information on do we think that my guess would be yes, but do we think that sometimes it is the parent or caregiver or family member's perception of the disability that impacts the social engagement and quality of life of the child, like contributing to the depression a bit just because of that? I'm so sorry. I'm
No, no, no. If I'm understanding you correctly, like to what extent is it the individual, the disabled individual versus the sort of social factors around them? I really want to shout out the article by Dr. Lunsford. He mentions specifically, I'm pretty early in my clinical training, but he mentions an experience that he had with a parent not wanting to get a wheelchair for their child, specifically because of some of the internalized social stigma, right? His recommendation as a physician was this wheelchair would be really beneficial for your child, you know, if only for improving his sort of sense of autonomy, his ability to do things on his own. And the mother, I believe, was pretty at it. She was asking for like more of like a stroller versus like a manual wheelchair. So I have not had that experience personally, but I think it definitely happens, and I would really, I guess, defer to that article that I mentioned, because Dr. Lunsfield does a really excellent job of describing some of the situations he's encountered.
Thank you.
Could I ask a question?
Yeah, definitely.
Okay. Um, as opposed to most of you that I see on here, I'm on the other end of the age scale. So I do have issues resulting from COVID. I've got long COVID, and I'm currently in a research study right now. I'm having difficulties with migraines, with especially the brain fog. And when I was I'm still working. Um, they didn't understand how it looked like from my side. Um, for 10 days, I slept for 18 hours a day. I could hardly get out of bed at the end of that time, but I was expected to work again. And I tried. And honestly, that was from December until May. And I still have problems days that I'm just really foggy, and I can tell the difference when I get up. I just don't feel right. You can't think, you can't concentrate, you can't focus sometimes. Is there anything that I could read that would validate what I'm feeling? Because sometimes I mean, they finally have realized at work that I can't work like I used to. I mean, I work 10 hours a day, and I'm interviewing, asking questions, and typing at the same time. So I think I'm doing pretty good. If they want to yell at me for misspellings, I'm sorry, but that's the best I can do. But I just understand how, especially somebody younger, that when people don't take you seriously, because those first couple months were awful. Nobody believes you, and there wasn't anything at the time to back up what I was saying. So are there any studies that I could read?
I do not know of any off the top of my head, but I think what I guess what you're alluding to is really this problem um, of invisible disabilities not being taken seriously, right? That quote
Yes.
from Dr. Orkin, I believe she has Ehlers-Danlos or something else, but it's one of those things where she, in her own words, she appears like a normal, healthy physician, but there's just days where she just can't do it, where she has like awful, just like physical symptoms. And I think, that quote really drives at the heart of the issue you're discussing. Like, people, there's a certain social expectation of what a disability looks like, what a disabled person should
Yeah.
look like, should do.
You should be able
And
to see a disability, but with some you can't.
yeah, exactly.
So
And Coral, I just put in the chat, there are several long COVID. You said you were part of a study. Some of those studies are now producing research on the effects, particularly the brain fog, and looking at other outcomes. So I can send you some of those
oh,
from
please, I would enjoy reading it. I joined the study, so whatever I am experiencing, maybe it would help somebody else.
absolutely.
But I wanted to read to see how to help myself. I mean, I probably could have retired 2 years ago, but I'm single. I can't.
Yeah. Absolutely. And it's interesting that you're talking about from the adult, but even from the kids and the adolescents when they had similar experiences, it was almost as if people felt like, well, you shouldn't have brain fog at all.
Yes.
And it was even more of a perceived battle. And again, at the crux of this is feeling validated and heard and how that might be associated with.
Yeah, I mean, they were taking outside signs like me still joking with people. Some days I can and some days I can't. Some
Right.
days I would sit in front of my computer and stare at the screen and think, I don't know what I'm supposed to do next. And I've done this job for 15 years.
And that's scary.
That's scary.
Absolutely.
Thank you. I didn't mean to talk
No,
so much.
this is all what it's supposed to be. Thank you, Coral.
You're welcome.
Well, we are close on time. And again, Alexandra, I appreciate it. I think it's wonderful that you're doing this level of work and your clinical studies at the same time. And hopefully, you thinking about these things will make you a fantastic physician when you're all done and thinking about these things. So we appreciate your time. As people head out, I did want to remind you the link to the evaluation is there, and you can let me know about certificate of attendance. But Alexander, thank you so much, and we appreciate it. Come back.
Yes, thank you.
Thank you all for having me. I really appreciate this opportunity, and you know, happy to chat about it.
Excellent, excellent. Thanks, everyone.
All right.
Thank you.
Take care. Thank you for having me.